Hello, my name is Jan Beecham, and I'd like to thank you for joining us and being part of BIANJ's annual seminar. Before we get started, I'd like to remind everyone to be sure and enter your full name into the chat. This is our virtual sign-in sheet. And if you're going to be requesting CEUs, remember that you must attend this workshop in its entirety. You must complete the workshop evaluation. And if you're required by your discipline, which is the CHES, CRCC, and social work, then you will need to go out to our website and complete a post-test. Okay, I'm going to be watching the Q&A so that we can see who's got questions. And then at the end of our session, then I will read those questions to today's speaker. And of course, questions are very much encouraged. We want to be we want you to be an active part of the workshop. The name of this workshop is Post-Trauma Vision Syndrome, a novel treatment approach to invisible symptoms. Our presenter is Karen Waters. Karen, who is currently an inpatient occupational therapist at Kessler Institute in West Orange, has for 28 years been a pioneer on the cutting edge of developing and designing innovative interventions for patients who have experienced brain injuries, strokes, and other neurological impairments. Throughout her career, she has been passionate about forging a collaborative, multidisciplinary approach between rehabilitative team members to ensure high-quality patient outcomes. Karen has been an integral member and leader of several teams which developed visual evaluations, cognitive evaluation tools, behavioral interventions, and novel approaches in the treatment of neurovisual impairments. Today, Karen will share with us some exciting new approaches to the evaluation and treatment of post-trauma vision syndrome. And so again, I would like to welcome Karen Waters to our workshop today. Thanks, Karen.
Thank you so much, Jan. It's nice to see you all here today. And as Jan said, my name is Karen Waters, and I'll be discussing how the visual process is affected by traumatic brain injury, resulting in a condition named post-trauma vision syndrome. I'll discuss a treatment approach which reduces the symptoms associated with PTVS, as well as improves the ability to function in everyday tasks as recovery is occurring. So, anytime that there is a traumatic brain injury or concussion, there can be a multitude of different symptoms that occur. Some of these symptoms that patients report include visual fatigue, eye strain, intermittent blurred vision, and headaches. These are commonly recognized as signs of difficulty with the eyes. However, people who've had a traumatic brain injury can experience these other symptoms as well, unrelated to structural problems in the eyes and optic nerve. And they actually arise from trouble with the visual process. These may include difficulties with balance, dizziness, vertigo, photophobia, or glare sensitivity, double vision. Some patients will even report to see the page move when they're reading, or difficulty functioning or tolerating crowded, busy environments. Some will have panic attacks and hallucinations in response to this visual information. The visual problems that persons with traumatic brain injury experience are often overlooked, and symptoms are often attributed to other problems. Unfortunately, when those other perceived problems are treated, they usually fail to stop the visual symptoms. Forgive me. So, what is vision? Well, vision, William Padula, who's a well-known neuro-optometrist in the world of optometry, defined it as an interactive process of motor and sensory functions. Our brains use our eyes to help organize and control the movement of our bodies, as well as to stabilize what we see around us. This is called the visual process. When it's out of balance, it interferes with all aspects of human performance, including cognitive perception. So it is really, if we really think about it, vision is much, much more than our eyeballs. It is really how our brains process information. And a common misunderstanding is that seeing or perceiving something with our eyes delivers information to the brain like a computer. But seeing is actually much more complex. It's related to movement, posture, balance, and our motor system in general. Because our brains coordinate these functions so rapidly and so well, most people take the entire process for granted. Only recently have we begun to learn more about how vision, movement, and perception are connected. So some processing of visual, or some principles of visual processing. First of all, we need to understand that vision leads movement, and that the visual systems and motor systems develop together and are very integrated. So if we think developmentally about a young child, as they're beginning to, say, sit up and they're reaching for a toy, it first is initiated, movement is first initiated when the child visualizes or fixates on the toy. If the toy, as the child begins to reach for, say, a ball, if the ball should begin to roll, there's a postural set adjustment that occurs as the child then adapts to reach for the toy. And a lot of times they'll fall over. But as they're developing, vision is the thing that first leads their movement. And with that premise in mind, we need to consider that faulty postural control and balance will impact negatively on the efficiency of the visual system. And vice versa, a faulty visual system will impact negatively on the efficiency of balance and movement. And TBI causes dysfunction with all these aspects, including posture, balance, spatial orientation, and binocularity. So anytime there is trauma to the head or the neurological system, it can produce dysfunction in the visual processing systems, resulting in the symptoms I mentioned before, such as headache, dizziness, visual distortions. And with that, when there's disruption to the motor, visual, vestibular, kinesthetic, proprioceptive, or postural systems due to concussion or traumatic brain injury, it causes the balance of these interactions of these systems to become disrupted, and aberrant adaptations will occur. So the brain integrates this visual information and combines it with sensory, motor, and vestibular systems. But we also really need to consider the visual process related to traumatic brain injury. Oops, sorry. And we need to understand that the process of vision is, in particular, we need to think about how the visual system was created. It grew and developed out of a normal relationship to the motor system. It's an action-based system. The developmental relationships to the motor system is important to consider because vision leads movement. And also, as I've mentioned, that visual processing occurs into the brain. When we think of these three principles together, the possibilities to maximize our clients' potentials through the reorganization of the visual processing capabilities after a neurological event is very important. It means that we can help our patients improve their function through the facilitation of normal vision combined with normal movement. So traumatic brain injury and vision cause problems with the eyes, and it can cause problems with the brain. In the eyes, we're familiar, it can cause cranial nerve impairments, which can affect visual acuity, visual fields, ocular motor dysfunction. But the emphasis of this lecture is not going to be on the eyeballs or the eyes themselves, but really on the brain and the neurovisual processing dysfunction as the brain processes visual information and how it does that. So some things you got to remember is that 80% of our sensory systems are dedicated to visual processing. And the latest in neuroscience research demonstrates that, as we know, that the brain is plastic. And so when we look at the visual process in relationship to human development, not just in the aspect of seeing, but in how it steers the development of motor and cognitive processes, you begin to understand that vision leads the way in the organization of the visual sensory process and neuroplasticity. 60 to 80% of all patients with concussion, mild traumatic brain injury, or TBI have experienced changes in their vision. And I remember when I first started working and began to do vision screenings at work on my TBI clients, I would never have guessed that it was such a vast majority of clients that have this problem. When we're working with patients in the acute rehab setting who are very new and perhaps have very severe brain injuries, there lacks the awareness of visual changes. Even in patients who are in the outpatient setting or kids in the schools, they're not always aware or able to articulate changes in vision because our reality is what we see, and it's hard to sometimes identify these shifts or changes in reality or in vision. But what we do know is that of the 60 to 80% of all patients with changes in their vision, we need to consider and recognize that specific visual impairments such as accommodative deficiency or vergences, saccades, orbital sensation, eyelid function, visual fields, acuity, color vision, and pupillary function, they're subserved by 7 out of the 12 cranial nerves. If you really think about it, it really articulates why these clients really need to have a detailed visual ocular exam by a specialist in this area, because our vision is such a very big part of our sensory system. So I'm now going to discuss a little bit of theory and neurology. So kind of hang tight, it's a little bit complex. But it helps to explain why the approach that I'm going to be articulating today in regards to these impairments is so effective. So a long time ago in 1968, a researcher, Colwyn Trevarthen, wrote a very interesting paper named Two Mechanisms of Vision in Primates. He was a researcher at Harvard and at Oxford, and he looked at the two processes of vision, one of which he called the focal process and the other the ambient process. He defined that vision is a bimodal process and that we require both focal and ambient vision to function. Trevarthen recognized that our focal processes were responsible for our higher order seeing processes. So focal vision, what is it? Focal visual processing, well, first of all, we have two types of vision, as I just described. The focal visual process carries images to the central part of the retina of the eye and helps us to see details. It also enables fixation, or the ability to look directly at something, and it supports attention and concentration. However, the focal process only delivers information on an object to the brain if the eye is directly fixated on it. Our focal visual processing is really responsible for detailed discrimination and visual identification. If you think about it, focal vision is what you think of when you see. As you're looking at the screen, maybe you're reading the slides, maybe you're looking at me, but you're noticing me. Your attention is on your focal vision, and it's a conscious choice. Our focal visual system, well, about 80% of the fibers that run from the fovea through the cortex are located here. These intercortex connections are then processed in the occipital lobe where an image formation occurs, which translates back to what we see. The parvocellular visual system is really the what of the visual system, and that's what our focal vision is part of. But interestingly enough, Trevarthen also recognized a secondary process, and this secondary process he called the ambient visual process. The other the ambient process delivers information to the brain from the peripheral aspects of the retina. Our peripheral vision, or what we see in the margins of our vision instead of what's directly ahead of us, affects our awareness as far as where we are in space and where things are relative to us. This part of our vision is very important to the body's motor system. It also serves to organize our focal process by spatially orienting us before we even look at details. The ambient visual process must work in conjunction with the focal visual process for effective vision. Trevarthan recognized this, and he described of the two processes that it is the ambient visual process that we are born with. And if we think back to infants, many of us may be familiar with the infants don't really see well. And at birth, they don't have discriminatory vision. The myelin of those fibers in the retina aren't even the fibers are not even myelinated at this point in their development. But what infants do see is they perceive movement, they perceive contrast, they perceive shape and form. And that's really the foundation of our visual system, which is the ambient process. And the ambient process gives us spatial orientation. So for example, again, if you're looking at this screen, you're probably aware of how high your ceiling is. You're probably able to notice out to your left or to your right that there's certain objects in your visual field. Now, you're not focalizing on them, you're just aware of them. You're aware that when you stand up, you're not going to bump your head. Even though you're not really looking at your ceiling, you can tell that. When we walk through a doorway, we innately can judge our space around us because of our ambient vision, giving us that perception of space or that spatial mapping, we're able to function. So our ambient vision is responsible for spatial orientation, and with that, our posture and balance. It's our peripheral awareness, and the ambient visual system is also always on to anticipate change. If someone were to begin to approach you from your side, you would immediately focalize on that person and come back to your task. 20% of the fibers for our ambient vision are located in the peripheral retina. And what's important is that these fibers translate directly to the midbrain, reaching then 99% of the cortex. And these magnocellular visual pathways are really the where of the visual system, where we are relative to it and where it is relative to us. So how these two processes work together? Well, the spatial visual process really links up this information, which provides us feedback about vertical and horizontal lines in our environment. The spatial process, together with proprioception, feeds forward with this information to create this like a platform base in our brain to provide spatial orientation upright against gravity prior to the image that we're noticing ever formalizing in the occipital cortex. This is very important. And this is important because we don't think of the ambient visual process. Our focal visual process is there to help us think about what we see. The ambient process is really preconscious. It's responsible for anticipation of change. The focal process is oriented to provide detailed information. And then the spatial visual process must balance out our focal process by orienting us to the greater spatial context and balance with focal information. So in summary, the ambient visual system must do what it does in order to keep us balanced. If we didn't have an innate processing of vertical lines, horizontal lines, objects in the space around us, we wouldn't be able to ambulate safely. We wouldn't be able to dress ourselves because we wouldn't be able to attend visually to the information in our periphery. It also, our ambient process really then, it's, as I mentioned earlier a moment ago, it's that platform based. And it links up the information that our proprioceptors and are receiving, the information that's coming in through our proprioceptive base of support. That information comes up through midbrain and then feeds forward to the higher cortices. It connects with the frontal lobes, the supplementary eye fields, parietal lobe, occipital lobe. And it's in that process that we create this mental spatial mapping prior to the visual image ever even being formed. When a concussion or a traumatic brain injury occurs at any point, it interferes with how this information is processed. So, you know, I often think I had this one young woman, she was a lacrosse player. And it got me thinking, you know, she was a state champion. She was an extremely good lacrosse player who sustained a concussion. And she was telling me some of the things that she does on the field. And I remember this, one of the problems that she was explaining is she couldn't catch the ball anymore. And if you think about it, that example, you know, before a lacrosse player is able to raise their stick to catch a ball, if you think about what happens in our brains before that ball is caught, the player is aware spatially of all the players around them. The player is aware of where their stick is in their hand. They're receiving proprioception and kinesthetic feedback as far as how their joints and their muscles are moving. They notice the ball coming at them, and they know they physically need to position themselves in a place to catch the ball. That ball is coming, but the whole time they're not focalizing on the trajectory of that ball. They're really aware of that ball, simultaneously processing all the visual information of the players around them, putting that together with how their bodies are moving to raise the stick and accurately catch it without exactly tracking that ball to the net. That's the ambient process combined with the focal process, really at its highest level of functioning. I think I skipped ahead. So some take-home messages here is that the ambient and the focal processes are really interrelated and codependent. They're organized as a bimodal process and they cannot function separately. Lower portions of the brain, such as the brainstem and the midbrain, are critical for the support of this spatial interface with higher cortices. The ambient visual process provides the plasticity of vision. Because it is a dynamic visual process, it's the reason why therapeutic interventions can actually work to reduce symptoms and improve function. It enables our higher order consciousness without having to think about things. You know exactly where to place your foot before you even walk. You know where you're walking without having to stare at your feet at the ground. You know, working in inpatient brain injury unit, most of our patients are visually oriented as they're beginning to walk again on their feet, on the ground. Well, there's that disconnect of the ambient and the focal visual process combined with usually pretty significant changes in their motor systems that force their eyes to work that. But what I found is with the interventions I'll describe soon, that when we can help rebalance the ambient and the focal visual processes, we tend to see in our patients less need to over-focalize on their feet when walking, for example, and able to process greater amounts of visual information. So this leads me to the meat of the lecture, which is post-trauma vision syndrome. And I'd like to talk now about post-trauma vision syndrome, which was first described by William Padula and Stephanie Argyris. They described this condition in a paper back in the 90s, 93 or 94, in a paper in the Journal of Brain Injury. And they identified this condition as they saw patients with the symptoms I described earlier, but they also noticed that there were very specific changes in their visual evoked potentials, or VEPs, that in traumatic brain injury indicated a dysfunction in the balance between the ambient and focal visual processes. When this dysfunction and imbalance occurred, there were symptoms that they later identified as post-trauma vision syndrome. So in any neurological condition, such as brain injury or even stroke, Parkinson's, MS, when this imbalance occurs between the ambient and focal visual processes, symptoms occur. So in post-trauma vision syndrome, the ambient visual process, which I described earlier, it loses its ability to organize information spatially. When that process is affected, that person becomes focally bound or overly fixated on visual details and has to work harder to use his or her vision. That extreme effort and intensity required to use the focal visual process leads to visual fatigue, headaches, and eye strain, even dizziness. Post-trauma vision syndrome can also cause individuals to visually fixate on individual letters or words when reading, and they have a difficult time releasing or moving their vision away from the letters and the words due to overfixation. This causes the words to appear to almost jump or wave or pulse, as some patients have described, and the person has difficulty reading. It can cause intermittent blurring and even double vision that some patients experience. Some patients with post-trauma vision syndrome also find it more difficult to function in busy, crowded environments such as supermarkets or shopping malls. They identify people or objects in their environment. They identify people walking around in their environment or objects in their environment as detail, something that requires over-focalization on, when it's really just the peripheral information. And that visual information then starts to be very confusing to these patients. In some cases, persons with very severe dysfunction of the focal and ambient visual processes will become anxious, leading to panic attack syndrome due to the way that their visual world is being reordered. So when William Padgel and Stephanie Ardress started to define this condition, they used visual evoked potentials, as I mentioned. And for those of you that aren't familiar, visual evoked potentials are, well, they place electrodes on the patient's forehead that read brain waves. And in this situation, they viewed a visual stimulus, in this case, a reversing checkerboard, black on white, white on black. The visual evoked potential records specific brain waves that can identify dysfunction in the visual processes. And they found that spikes in certain waves of the visual evoked potentials were consistent among patients who had the symptoms I've described with post-trauma vision syndrome. And what they found also then were later on, once they have identified these evoked potentials, they also came up with treatment interventions that normalize the visual evoked potentials, which I'll get to in the next phase. So in the slide in front of you, you'll see kind of an overview of post-trauma vision syndrome and what occurs. So what occurs is an imbalance between the focal and ambient visual processes. And there's this mismatch of information that occurs between the visual, kinesthetic, proprioceptive, and vestibular systems, which causes post-trauma vision syndrome focal binding. And focal binding is really an over-isolation on detail. And this creates a spatial disorientation that becomes more severe with peripheral movement. This then forces an increase of the individual's concentration to single out detail to exclude some of the peripheral information, and causes then a perceptual tunnel vision, resulting in visual motion sensitivity. So if any of you have ever driven at night in the middle of a snowstorm, you may experience what it might feel like to some of our patients. So you're driving at night in the middle of a heavy snowstorm and you accidentally hit on your high beams. What occurs is that there is a barrage of snowflakes. All you see is the detail of the snowflakes, and it's very hard to see the road. You can't see the forest between the trees. So what you do, if you're normal, you switch out of your high beams back into your low beams and continue the road. Patients with post-trauma vision syndrome can't flip their low beams back on. The entire world is a barrage of detail. There's a loss of balance between ambient visual information and focal, and everything becomes over detailed. And if you think about it, if you were to drive in those conditions with your high beams on for a period of time, 1 or 2 hours, what would happen? Well, you'd probably get a headache. You might even, when you get out of the car, feel a little bit woozy or even dizzy. There's a sense of motion without feeling the spinning sensation. You might have a lot of tightness in your shoulders or in your neck from all the clenching that occurs. And if you think about some of our, I'll use concussed patients, many of them complain of neck pain, shoulder pain. They have headaches. They have a sensation of dizziness, even though perhaps vestibular causes have been ruled out. They're having perceptual distortions and they don't feel right. It's not unlike what occurs during this. Some of the characteristics and symptoms of post-trauma vision syndrome on ocular exam, when they're seen by a neurooptometrist, they might have exophoria or exotropia. Convergence insufficiency is usually almost always part of this constellation of symptoms. Accommodative insufficiencies, ocular motor dysfunction, and increased myopia. The symptoms that they describe are often double vision or diplopia or blurred vision. Because remember, double vision is not always two images. Sometimes it's one image, but slightly off. Sometimes as the eyes are focusing and trying to refixate to receive better clarity of vision, patients may even get the sensation of motion, hence that visual dizziness that occurs, right? If you're going from single vision, if I'm trying to mimic this here, to double vision, to single, there's a sensation of motion. One reason why they can't tolerate those busy moving environments and they get headaches. If you picture, if your whole world was always in the sense how much of a headache you might get, or that your eyes hurt, or you have asthenopia or photophobia or light sensitivity. Some patients even have hallucinations. I remember this one guy I worked with, he was feeling pretty well after his mild traumatic brain injury, and he and his wife went to Atlantic City to a casino. Well, he walks in, and within about a minute, he turned to his wife, and he was cognitively able to describe his symptoms. And he goes, "Honey, you see all those snakes rolling around on the ground?" His wife looked at him like he was crazy. Well, he said, "Yeah, look at it. There's snakes, monsters on the ground, green monsters." And she looked at him, and she looked at the carpet, which happened to be great big giant green leaves. She told him what he was. And he looked, he goes, "I'm telling you, I'm out of here." And he left the casino and sat outside, waited for her to do her thing and joined up. Well, if you think about what happens, a patterned, a lot of our patients can't tolerate busy patterns, right? Wallpaper, supermarkets, malls, casino flooring. And to him, there was this visual distortion that appeared. Now, he was cognitively able to describe his symptoms. Many of our patients aren't. And sometimes what seems to be a hallucination might actually really be more of a visual distortion. In the next slide, I'm going to show you a very short movie. I'll encourage you to turn your volume down because I had to upload this from YouTube and it's a little loud. But when I show you this video, I'd like you to try and really look at the screen with a large, soft focus and try and envision yourself within this. I think I have to turn my volume down.
Go first.
God.
I can actually see it underneath too. Woo! I'm already dizzy. We did one of these at Entertainment Junction the other day, a couple weeks ago, I guess.
I don't know about you, but when I look at this long enough, I even think I get a little bit dizzy myself. I'm going to have to pause here. So in some of these videos, or in some of these attractions, as you've noticed, whoops, there we go. Did that come through, by the way? Jan, give me a thumbs up. Did that audio play? Did that video play okay?
Yes, it did.
Okay. I had a weird pop-up on my screen that I wasn't sure if it indicated malfunction, but in any case, so in those spinning tunnels, in the old days, they used to have in fun houses a black and white wheel that you could walk through, very similar to the Ripley's tunnel. And of course, you experience as you walk through, you have the sensation of spinning and you lose your balance and you trip and you cross your legs and hopefully you don't fall over. But there's a secret to get through those tunnels. And usually, if you look right through a tunnel at the wall, at the distance, you'll see a visual target to look at. And many times in fun houses, it's a picture of a really creepy clown. Well, when you look at that creepy clown and you give it a hard stare, you can usually walk straight through that tunnel without having that sensation. Because what you do in that case is you focalize, you over-focalize, you tune out your ambient visual information and hyperfocalize on the target ahead. It reduces your symptoms. But there's although it's a Band-Aid solution for a problem, if that was how your brain was functioning all the time, you would experience many of these symptoms that I've listed here below. Dizziness, lightheaded, disorientation, and listed here are some of the complaints that our patients have functionally. So if you have a patient upon your evaluation that is starting to complain of some of the symptoms listed here, you might want to start to think about post-trauma vision syndrome. As I mentioned before, they have a hard time tolerating crowds or malls. There's a condition called supermarket syndrome, where when walking through the aisles, they perceive that the aisles of the grocery store are in a perpetual motion, making them feel disoriented and dizzy. A lot of these people have visual motion sensitivity in the cars. And if you think about what happens as a driver or passenger, although we're looking ahead, we're constantly, our visual system is having a barrage of visual information on our left and on our right. We're tuning out that information, simultaneously attending to the cars on our left and our right so we don't crash. But sometimes that constant motion is too much for these patients. There's a mismatch of what they're looking at hard straight ahead with the soft information in the periphery. A lot of these patients will complain of problems scrolling on phones or scrolling on screens. That's a big one. And in today's digital age, it's a huge disability if we can't tolerate our phones and our screens. I had a patient once, she was a caterer, and after her concussion, she had fallen off of a horse. And after her concussion, she couldn't return back to work because the act of chopping up food was making her so dizzy, she was nauseous. And if you think about the repetitive motion of chopping, it's not too unlike the motion in a car, watching a busy movie or an action film where there's lots of action moving back and forth. These symptoms are debilitating for our patients. Listed here are just some more ways that these symptoms affect patients. This is an image of what it feels like. And if you have a soft look, you might even start to feel a little bit, almost like the page is moving slightly. If you turn your head a little bit left and right, and you're kind of noticing the aisles of the supermarket, this is how our patients feel, but all the time. In this image here, I'd like you to take a look at the screen and try to think about how do you make this wheel stop? And then how do you make it go? Since this is not really audience participation at this point, I'll tell you. So if you notice, if you look to the outside, the black perimeter of the screen or somewhere else on the screen, but you're aware of the image, you'll notice that the rate of spinning increases or moves. Now take a moment and look right at the center of the screen or of the pinwheel and look hard, stare at it. And you'll start to notice that the wheel slows down or even stops. Well, what you've done there is overfocalized, and that stops the ambient visual process from functioning well. If you think about patients that we have with vestibular conditions, for example, or concussed with a lot of these symptoms, what they're needing to do a lot of the time is to have that hard focus. That hard focus stabilizes their world. And although it stabilizes their world, if you're in a perpetual state of overfocalization, that will again contribute to your headaches, your sense of dizziness, because you're no longer processing your ambient world, right? You will have a lot of neck strain and tension. You may have balance problems because you're so overfocalized. So what do we do about it? I'm going to highlight very quickly, because it's a much more in-depth treatment approach, but some things as therapists that we could do as teachers or educators and as medical professionals. So the treatment approach that I'd like to outline includes 6 things: a vision screening, binasal occlusion, the use of rotatable yoked prisms, peripheral awareness techniques, neurovisual processing rehabilitation, and patient education. Well, the first step to anything is a good evaluation. Occupational therapists have been trained in performing comprehensive vision screens. And in their vision screen, many times, many of us will use a checklist called the BIVSS, or the Brain Injury Vision Symptom Survey. And at the end of my presentation, there's a bunch of, I'll say, bonus slides or extra slides that you can reference after the presentation's posted that'll give you links to find it. It's a very quick and easy survey. Once a vision screening is performed, assuming that dysfunction has been noted, and an OT might find that they have an exophoria or a convergence insufficiency. With that, combined with clinical presentation and symptoms, one might decide to refer to neurooptometry, a developmental optometrist, or a neuroophthalmologist. And as a real quick blurb about what those professions are, each one of them is actually very key to our rehab team, but each one of them, although similar, is actually distinctly different. So in a neuroophthalmologist, they're a medical doctor. And after their training, in their bag of tricks or things they can do to help a patient, they are diagnosticians, they are surgeons, and they provide medical treatment, medications. They're also trained in the prescription of lenses or prisms. However, the first three, surgery, medications, and diagnostics, are really kind of the meat and potatoes of their practice. It's what they do best. It's what they're most trained in. Lenses and prisms, some neuroophthalmologists are excellent. Others, it's less of an area of interest for them. In neurooptometry, it's a subspecialty of optometry. They have about the same amount of years of training as medical doctors, but with an OD next to their name, or a doctor of optometry, they're more concerned with how vision functionally impacts the individual. And in their bag of tricks, they are diagnosticians. They offer medications for eye conditions. And the real art of their practice, or bulk of their practice, is prescribing specialized lenses and prisms, as well as specific therapies. Relative to the therapy community, I find that neurooptometrists, relative to brain injury and the problems that I'm referring them to, are usually particularly helpful. Developmental optometrists also are very helpful in this way, particularly for the pediatric population. An optometrist may evaluate them, but I also consider in my symptoms or in my evaluation that they might need a referral to physical therapy or neuro ENT. Sorry for the typo there. I usually will refer to a vestibular certified therapist, physical therapist, to rule in or rule out a vestibular component. Sometimes I'll need to refer to neuropsychology. Many of these people, because of the difficulty processing visual information, or like the guy who saw the green snakes, that's a very scary symptom. And, particularly psychologists that are trained in performing CBT, or cognitive behavioral therapy, are very helpful for these patients. So the other thing that we can do as therapists or as clinicians is a technique that's been around since the ancient Greeks, actually, which is tape on your glasses. The fancy medical term is called binasal occlusion, but essentially it is tape on your glasses. But there's real validity in research to support why something so simple works so profoundly. Binasal occlusion reduces overfocalization, and it restores the person's ability to process ambient visual information. If you think about the nature of that photograph, right? It increases the person's attention to the periphery and reduces the tendency to overfocalize. It's best to apply it with guidance from an optometrist. But once we do this, as therapists, what I'll often do in my evaluation is I want to evaluate how it's helping my patients. I want to know, is it working? So I usually encourage my patients to try it. There's some YouTube videos that I'll link them to watch and learn a little bit. A well-educated patient is my best client. And once I've done that, I'll look for a reduction of symptoms. Sometimes I may have them read with and without their glasses, with and without the binasal occlusion. I'm going to be listening for an increased fluency of reading. As I mentioned in another example, patients who overfocalize tend to read letter by letter, word by word by word, where when you're processing in the act of reading, we're actually visually attending to what's coming more than what we're actually looking at. So binasal occlusion reduces focalization in reading. or when driving, which is often one of my clients' largest complaints. Are they able to drive longer? Are they able to drive with less symptoms? Can they drive at night? Can they drive at rain when the windshield wipers are going? I included here just a slide for those who like to read a little bit about research about why binasal occlusion works. But essentially, the theory is that it reduces the overfocalization and improves the ambient visual processing. Another technique therapists can use is what's called rotatable yoked prisms. And this is a picture of a young woman wearing them. And they kind of look like Mr. Magoo glasses for those of you that remember that old cartoon. Rotatable yoked prisms are an optical tool that refracts light onto a different place on the retina, altering the orientation of a visual image or the perception of space. They're used monocularly or binocularly to correct for deviations in eye alignment or to alter perception of space. So in the pediatric population or people who have a fixed and long-term strabismus, an optometrist may choose to use it monocularly to refract the image to a different place on the retina. So if the eye is pointed very far outward, the prism will refract the image onto the retina over here instead of where it would be normally, thus improving the ability of the eyes to fuse on a single target, reducing double vision. They can also be used in a yoked fashion or binocularly to change the perception of space or to alter postural alignment by shifting the perceptual midline orientation, subsequently the perceived ego center of mass. Yoked prisms aren't seen, but they're felt. And if you ever have the opportunity to try a pair on, if this was a face-to-face presentation, I'd have my prisms out for you and I'd let you try them, because as soon as you put them on, you will know exactly what they do, because it shifts your center of gravity. It shifts your perception of midline. I'm going to go very quickly through these next 4 slides. You can look at them on your own, but a base down prism affects the perception of the horizon, moving it upward, thereby facilitating an extension response. In my patients with Parkinson's syndrome, they're terrific in a base down format. A base up format, a lot of our brain injured adults have a tendency to come forward. And when we use a base up prism, I'm sorry, I said this backwards. When I'm trying to facilitate an extension response, I'm going to use the base down prism. So if my brain injured clients who might be more forward, I'll use a base down prism to facilitate cervical capital extension, back extension, and reverse. In the Parkinson's folks, oh my gosh, I'm getting all tongue tied here. It's been a long lecture. I'm not used to talking so much. But the base up prisms have the effect of moving the perceived horizon down, thereby facilitating a flexion response. I was right the first time, sorry. At Kessler Institute, they've done some really nice work with the evaluation of prisms in the treatment of neglect. And this is similar to how they're using them here, but we can also use them for patients with hemiplegia to shift the postural set to the right or shift the postural set to the left based on the orientation of the prisms. It's great with hemiplegic patients as well, as far as improving their center of gravity to be more midline. Why should we use them? Well, we should use them with the support of an optometrist. We want to progressively alter the perception of space, which challenges and facilitates the ambient visual process. We combine that with the facilitation of normal movement upon a normalized visual system. In this example, this is a patient. I can't give you details about what occurred to her, but this is her with or without her prisms. And I'll show you parts of this. So this is her with her prisms on. And the neuro-optometrist here is evaluating what type of prism works well for her. He's altering the position of them. He's altering the diopters of them as well. And now she's taken them off. Her greatest complaints were that she always felt that the room was tilted, as you can see. To her, it feels that the floor is slanting down.
You can use the wall if you need to.
Notice the change in her tone, and she has no physical limitations. No hemiplegia, no movement problems. Just in the interest of time, I'm going to end it here, but you get the sense of how it can be. Just by changing how we see affects how we move.
I just record this.
Another therapeutic technique that OTs can use are, I'm going to outline quickly about 4 different types of treatment just to give you a few little pearls. But there's a peripheral awareness techniques. One exercise is what's known as McDonald cards because Dr. McDonald invented them. But if you can kind of try this at home, if you keep a very soft focus on the spot in the middle of this card and you relax your gaze, but keep a soft focus on that dot in the middle, and the object is to read the letters going around. So you would keep a soft focus on the center dot and the patient would read LHYE, TAPS, FKMN, and so on. And that's one exercise. Again, the focus is always center, but the attention is in the periphery. Great tool is the BITS or the BIANJ integrative therapy systems. And there's a lot of different programs on here that can be used. Again, the general principle is a soft central focus with attention to the periphery. In this example, the therapist is asking the patient to look at the center target and tap the small red, white, and blue dots in the periphery. The patient needs to attend to the center target as the wheel spins around. Thumb rotations. The patient extends their arm looking at their thumbnail and they move their thumb in a figure 8. Whatever the thumb passes over is what the patient needs to call out. So again, the focus is on the thumb, but the attention is on the objects in the patient's periphery. An Allura card, it's similar to what you saw before, but this one is kind of neat because I'll do it in front of a television screen. I'll do it while the patient is walking outside. I can use the motion of the background to really kind of trigger symptoms and help the patient habituate. Another technique is what's known as neurovisual postural therapy. And although we tend to think of our individual sensory processors like our ears, eyes, nose, tongue, mouth, and fingers as separate systems, we also have specialized, we tend to think of them as separate systems, but really they're all integrative. And patients with traumatic brain injury who have visual dysfunction can experience a lot of problems with this area. NVPT, in the premise here, therapists provide normal movement opportunities combined with the use of rotatable yoked prisms to integrate responses that demand a better function of the kinesthetic, proprioceptive, and vestibular experience that can be linked to vision. So what it really does is it helps to match the feeling of movement with the seeing of movement. Guided movement experiences, when combined with the use of prisms, it really amplifies the person's intrinsic knowledge and response to spatial relationships, and it stimulates a new orientation in which the body can move in. NVPT affects the spatial visual processing dysfunction and its relationship to the proprioceptive base of support. The spatial visual process can become compromised, as we've learned, which can lead to dysfunction affecting balance and posture, which then increases the risk of fall affecting postural tone. So this therapy really works with the visual spatial process and the base of support to reestablish the integration of these processes. Integration of these processes rehabilitates the organization of the spatial visual process, which affects positively higher order vision, executive processing, posture, balance, and binocularity. And the last aspect that I'll talk about, and Jan, how are we on time, by the way? Can you give me a number of minutes we have here?
We have about 10 more minutes before we need to do Q&A.
Excellent, perfect. We're right on track. So with patient education, as I mentioned earlier, a well-educated customer is our best client. The general principle is that we want to help our patients understand that by reducing their visual demands, it can help keep their tank from running out. I found, practically speaking, we can help clients with post-trauma vision syndrome as an outpatient in about anywhere from 15 to 25 sessions, based twice a week, based on how embedded or how long-term the problem has been, what other comorbidities or vestibular complications they may have had, et cetera. But in general, it's a very responsive, the visual system is very responsive to treatment. But in those times, in those 2.5, 3 months of therapy, the patients are still, some of them, trying to work, trying to perform basic ADLs, trying to function within the home. So it's also my job to help them to be able to live in the process of getting better. As I mentioned, for many patients, tolerating screens is really difficult. So we can adapt their screen. We can offer them an amber backlight. We can reverse the coloration of their screen, like black on white instead of white on black. There's blue light filters you can purchase on Amazon that drape right over the screen that help dampen down that light sensitivity and glare. We can sometimes either increase or decrease contrast. And that one kind of depends on your patient. Some prefer it more dim, some find more bright. But you also need to consider that you can adapt the computer or any screen with text to audio or audio to text. One of the apps that I really like, you can purchase for about $10, I think it is called Voice Dream Reader. And this is an app that converts any text on a tablet or phone into audio. There's also adaptations you can put to the text that will highlight a word, highlight a line, highlight a paragraph. It's very flexible for adapting font size. You can have, if your patient's trying to read an email, you can have only one line at a time come up on the email. It's very flexible and it can really reduce the visual demands. You can improve their patient's lighting. A lot of these folks can't tolerate or can't stand fluorescent lighting. So one of the things you can do is encourage them to use incandescent light bulbs. Window light or natural light is usually more tolerated, sometimes with a light screen over the window. You can reduce glare. Using gooseneck lighting, task lighting is also very important. And some patients prefer a brighter task light with dimmer ambient light, and some the reverse. And with this, I would say that based on your patient's symptoms will help you determine what adaptations will make the most sense. Typographing is the word that we use to describe changing the text, whether you enlarge your font size and text and spacing. You might decide to use bold text. With these patients, we need to consider their physicality. How are they sitting? Do we need to change their positioning at their workstations, whether it's standing when they're being a caterer or sitting? Are they seated properly at good alignment? A lot of patients will complain of cervical involvement or cervical pain with a lot of brain injuries and concussions. There's whiplash injuries involved. And sometimes angling the workstation to be at a 45-degree angle can be helpful versus at 90 degrees to reduce the amount of cervical flexion. Are their feet planted firmly on the floor? Is the desk height at the right height for their body size? Reducing visual clutter or reducing the peripheral stimulation is also very helpful. There's just less for the brain to attend to. Certain energy conservation techniques, there's a rule called 20-20-20, and if you've never heard about it, architects use this all the time. And essentially the 20-20-20 rule is that every 20 minutes, you are to look 20 feet away and hold your gaze for 20 seconds before you come back to your near-point tasks. I encourage my patients to schedule rest periods. If they know that they get a headache or they start to get dizzy or that the letters on the page are jumping around after 15 minutes, every 10 minutes, I might encourage them to take a visual rest break. maybe do the 20-20-20 rule at 10-20-20. Pacing strategies. You want them to stop doing the provocative task before their discomfort reaches, say, a 5 out of 10 as far as their level of discomfort. So when they're at about a 4 or 5 out of 10, that's about time to take a break, bring their symptoms back down to a more manageable level, proceed with the task so they can pace themselves out through the duration of their day. You need to know what time of day your patient has the most difficulty with, morning, evening, and night, and you gauge your challenging and your easier activities accordingly. Optometrists will prescribe special lenses such as a low power base in prism for distance or low power base down prism for reading. They can prescribe specialized tinted lenses as well. So the 6 things that I just outlined are really kind of the hallmarks of developing a really good treatment plan for patients with post-trauma vision syndrome. So there's some other things that are up and coming though too. Dr. Padula won the most innovative award last year at the ACRM for his new device called the NeuroOptract. And it's the first gait mat that can measure the center of mass dynamically during ambulation. What's really neat and innovative about it is that it provides a rating for the risk of fall. And then it gives, through different software, it gives the evaluator tools to utilize and prescribe specialized prisms and specialized therapies customized to that patient's gait imbalance that will then can be evaluated real time to determine if it's reducing their risk of fall. So it's not out yet. I think it's going to be released sometime in the next 6 months, but it's a really, really cool new technology that's coming out. So a lot of times people want to learn more about this, and I hope that this lecture has inspired you to learn more. You know, if you're like me, the more you learn, the more you realize you have to learn. And it's been a really exciting area for me in my practice in developing. And I think what's really motivated me the most is that it works. There's a lot of good research to support each one of the treatment techniques that I've outlined, and I've provided some resources at the end for that. But really the proof is in the pudding. And, you know, I'm really excited to say that I think that this is an emerging area of interest for a lot of clinicians, which will then spur more research. You know, I know some of the other major traumatic brain injury centers down at Shepherd, they have a very strong program with this. And even our neighbor here in Allentown, Good Shepherd Rehab, is a very robust neurovisual processing center, if you will, that utilizes this approach with some very good results. I heard through the rumor grapevine that Shirley Ryan is developing a program based on this approach, but I can't confirm that. It was heard through a friend who heard through a friend. So, but I know that some of the other, I know that some major centers are very interested in pursuing this, both in inpatient and outpatient levels, and even in the schools. Some continued learning I have here. There's a few places you can look. There's a neat article on VMS, visual motion sensitivity, that I included a link here. The BIVSS is a nice survey. You can download it. It's free. Neurovision Rehab, or the Neuro-Optometric Rehab Association, has tons of literature and information about this. Padula Institute, Dr. William Padula, who's an OD, has his own website, and he has a lot of really good research and articles and what's up and coming in this area. And for those of you that are looking for CEUs specific to this, Vision Education Seminars and PESI, PESI always have a bunch of continuing ed courses discussing this topic. And I'm not going to get into the bonus section because, Jan, I'm assuming we're probably about time for Q&A. Would that be right?
That is correct.
Okay,
We have one question.
sure.
Are there types of injuries or ages that respond best to this type of treatment?
That's a great question. It's been my experience in working with, I don't work in young pediatrics, but I've worked with many teenagers, ages 14 and up. as well as older adults, that they all respond. And I can't say that an age group responds more or less favorably, although actually I'll take that back. Children and teenagers, young adults do respond very quickly. They have a very robust response. Older adults who've had longstanding Parkinson's syndrome or old strokes, they also respond even though they've been told that their condition is permanent. Again, with the plasticity that we know the brain has even many years post-incident, knowing that the visual system is a plastic process, there's room for improvement. And I think like any of our clients, there's always a large continuum of who responds and why. There's many comorbidities that patients will have that will affect their progress. The length and the severity of the injury, compliance with home exercise programs. There's so many reasons why people all respond differently, but it's been my experience that the patients all respond well.
Okay, our next question, could you provide the name of the text-to-voice app that you mentioned previously?
Sure, it's called Voice Dream Reader. I think it's $9.99, at least it was a couple years ago when I bought it.
If anyone has any other questions, just go ahead and enter them right here in the chat. We'll get a response for you.
But while people are thinking, oh, did one pop up there? Sorry, Jan.
Yes, how do prisms work if the client wears glasses already?
Good question. Believe it or not, we wear the rotatable yoked prisms on top of their current glasses. Now, what I will say is many brain injured adults, if they have not been evaluated by a neuro-ophthalmologist or a neuro-optometrist, I've often found that a change in their lenses makes a change in function. Many clients, particularly those that are 45 and older, have progressive lenses, and they really are very difficult for patients with brain injury to tolerate. And if you think about the functionality of it, it makes sense. With progressive lenses, you have to train your brain knowing where to look, whether you're reading, intermediate, or up. And if you've ever worn progressive lenses, the change from each of those in a very small area, it's very specific. And so what happens if you're looking in slightly the wrong place, you're going to, in the normal population, get a distortion of vision. In brain injured adults who have multiple visual issues and motoric issues, it's much worse. So to answer the question in the short way, you would use rotatable yoked prisms on top of their regular glasses. They can also be seen by a neuro-optometrist or neuro-ophthalmologist for ground-in prisms for correction of vision.
Does this treatment work less effectively the more time has passed since the injury or issue, or does it continue to be effective?
That's a good question. What I would say is that patients who have been focally bound or who've had post-trauma vision syndrome for a very long time, 4, 5, 10 years, like any problem, it becomes more embedded in the brain. And since we're really working through the neuroplasticity process of the brain, it becomes a little bit more challenging, perhaps taking more time to help improve symptoms. I'd also be remiss if I sounded like this was the perfect cure. If it was that great, we'd all be doing it by now. Like any therapeutic technique, it has its place and it has its role, and it can help. For patients who've had problems for a very long time, it takes more sessions. And the reality is insurance usually won't pay for all those sessions. But there's ways to be creative. If you have an engaged patient who's good with home exercise programs, I've often seen some patients for one time a week with the promise, if you will, of being dedicated to doing their home exercise program several days a week. If you happen to have one of those, or if you can help compliance with home exercises, they do very, very well as well. So yes, is the answer. It does take longer. They may not get as far. If insurance was never an issue, I would predict that would have a lot more success, but that's not the reality of the world we're in.
Any feedback or suggestions for clients who are also struggling with common symptoms related to PTSD, like hypersensitivity and hypervigilance? And do you have any tips to differentiate between similar presentations?
Okay, so the first one, I think, when therapists can work collaboratively with psychologists and psychiatrists, the patients have the best outcome. I would hope that your clients with PTSD would have one of those professionals on board. I'm going to go on the assumption that they do. If they've been diagnosed, somebody did that. What I encourage my patients who have psychiatric issues such as PTSD, major depressive disorder, bipolar disorder, depression, because many of our clients do, I try and find out from the psychologist what are some strategies that those persons are using, and I incorporate that into my treatment plan with them. I will also offer the psychologist some things that I'm encouraging the patient to do to see if they might be able to help support that. Usually, practically speaking, it's compliance with home exercises and helping the patient gain the awareness, understanding that intrinsic motivation to actually carry through with something that can be difficult. So I think collaboration is really the key to being able to work with those different diagnoses. I don't, as an occupational therapist, I wouldn't diagnose or delineate the two, but let's face it, they're people. So all of that is a part of their makeup when we see them.
Okay, I don't see that we have any more questions. It seems like we've covered everything.
Great.
So I guess saying that, we'll just go ahead and close our workshop. We have just almost run out of time. I would like to remind our attendees to please enter your name in the chat to sign out. You need to complete the workshop evaluation for this workshop, as well as all of the workshops that you've attended today and the keynote address. Be sure and check on the BIANJ website to make sure that you don't need to complete a post-test. If you are getting CEUs as a CHES, a CRCC, or a social worker, you have a post-test that they require you to complete. So you'll also need to do that in order to earn your CEUs. So we'll close this workshop at this time and ask that people move on over to the closing remarks in just a few minutes. Thanks, everybody.
Thank you. Jan, I'm going to stop sharing and say goodbye.
Thank you. This has been great.
Thanks.
Bye-bye.
Bye.